I've been involved in both inpatient and outpatient, but not everybody may be able to do that wide of a stretch.
Prescription drug monitoring program, what role does that play in your day-to-day lives as clinicians and as stewards of the opioid crisis?
I've been doing clinical pharmacy pain management for pretty much the entire time that my state has had access to that information.
There is a lack of education when it comes to pain management and specifically pain medication management.
I wanted to grow up and be Bob Vila.
I always have to ask myself and my trainees that, are we using it appropriately?
I'd like to see in the future is patient empowerment.
We are really there to take the practice to the next level through that collaboration, and that's what PainRX is really offering.
Welcome to the Next Orbit podcast, where connecting healthcare's data is the next frontier. We take you inside conversations with policymakers, healthcare leaders, disruptors, and visionaries who are pushing boundaries in a system that resists change. Explore how modern technology can remove barriers and improve care at scale. It's about ditching inertia and building smarter. For insiders, innovators, and anyone ready to navigate what's next, this is your launchpad. Here is your host, Ben Wade.
Hi, and welcome to the Next Orbit podcast. I am your host, and today I'm thrilled to be joined by two pharmacy trailblazers. My first guest, a 15-year veteran as a clinical pharmacy specialist and practitioner with an acute focus on opioid stewardship and managing complex pain syndromes. In 2023, she made history by becoming the first clinical pharmacy practitioner in her state to obtain a DEA license, allowing her to manage opioid use disorders independently. My second guest, also a doctor of pharmacy, pioneered a opioid stewardship program that slashed opioid use by 50% in internal medicine wards. He's also a prolific content creator on LinkedIn, sharing clinical pearls and insights on pain management. With that, I'd like to welcome Shelley and Sing Ping to the show. Thank you for being here.
Thank you.
Thank you for having us.
So today we're going to talk about prescription drug monitoring programs. Just to give you, the listeners, a brief background on what is a prescription drug monitoring program. It's a state-run electronic database that collects and tracks prescription data, typically reserved for controlled substances, but some states do track all medications. They're not anything new. So the first or the longest running prescription drug monitoring program goes to California. It was started in 1939. And as you can imagine, it was a much more paper driven process back then. But the idea is not new. We've just seen a greater adoption over the last decade as a result of the opioid epidemic. What is an opioid steward or a steward of opioids?
That's a really good question, Ben. So the way that I like to think about opioid stewardship is think about whether or not we are using the opioid wisely and appropriately, right? Because in a lot of cases, just because we see that an opioid is being prescribed, I always have to ask myself and my trainees that, are we using it appropriately? Meaning that, is the indication correct? Is the duration appropriate? I mean, there is a lot of gray area involved, right? No doubt that there's a lot of gray area involved when it comes to opioid prescribing. But then when we think more about the appropriateness, for example, does the patient have any kind of underlying psychiatric conditions that we need to be concerned that maybe we need to dose it a little bit more wisely and appropriately? And those are the cases where a pharmacist, especially like a pain specialist, can really have a big role. And that is really how I think about opioid stewardship.
Yes, and I would agree with Sing Ping. It's very synonymous with antibiotic stewardship. So some people are well aware of, using the right antibiotic for the right bacteria for the right amount of time. So it's the same thing for opioid stewardship, which does not mean that nobody should get opioids. And that's maybe a misconception. There is still appropriate use of the higher risk opioids. So we help with those decisions, evaluating risk, like Sing Ping said, with mental health background, maybe respiratory conditions that might contribute to a potential respiratory event. And it's across settings. So it can be inpatient, like Singping is mainly inpatient with opioid stewardship. I've been involved in both inpatient and outpatient, but not everybody may be able to do that wide of a stretch.
Appreciate that explanation. I think it's a common misconception that being an opioid steward or a steward of opioid prescribing means that you're attempting to slash or cut out opioids at all cost, when it sounds like it's more of making sure that you're prescribing responsibly and doing all the things that you can to prevent overuse or misuse of controlled substances. So what role does the PDMP play, the prescription drug monitoring program? What role does that play in your day-to-day lives as clinicians and as stewards of the opioid crisis?
Excellent question. Undoubtedly, it's at the forefront of what I do in working up every case. I've been doing clinical pharmacy pain management for pretty much the entire time that my state has had access to that information. And so I've evolved with it and grown with its expansion and communication between states, which may come up a little bit later. But so I'm working in a health system where it is integrated, and we do get information from multiple states on a patient, and it's very easy to access. An example would be that it's just ingrained in my DNA now that the first thing I look when I get a question is the PDMP. Every time, regardless of the question, on a complex pain patient, I go and look at the data available. And it really can change the course of what's going on with the patient, how I treat the patient, or how I how I manage the patient. But it's not always done, even in a system that has this all very integrated and what we would call an easy button to make it where they don't have to jump out of the system and sign in. I had a case today that the patient was saying, that he was on a medication, specifically oxycodone, and said 40 milligrams a day. Well, the team, great for them, they went and looked at the PDMP, and it showed nothing. And so they went back to the patient and posed it, and he said that he's like, I told you, I obtain it privately, and that was it. And it was posed to me as that, patient says he uses this, it's not on PDMP, having a hard time managing pain. And what had happened was the patient was using it, had an illicit source that he wasn't being forthcoming about. And that really changed. Like, the doses they were giving him weren't even coming close to what his usual daily dose was for years. And it doesn't take a pain specialist to just ask a question. It's a medication reconciliation, or a drug, however you want to say it, a drug reconciliation that as pharmacists, we do all the time. Every encounter, we're asking if there's any changes. Are you taking anything new? Or how can I don't see anything on the PDMP. Is there anything I should know about and to better take care of you? And that's really how you pose it, where I think he initially thought he was going to get in trouble from what he was saying, but this isn't coming from a punitive standpoint. It's a safety standpoint and providing the care that he needs. So it really was an avenue for us to end up, for myself and my trainee to work with him and take over the management of all things opioid for him. And so it made a big difference. So every day.
So you hit a lot of high points when it comes to evaluating PDMP, and I really agree with everything you said there. And one of the things that when I remind myself, why do I do PDMP, and really is doing PDMP isn't a step, like isn't a checkbox for us to just check the box or maybe just glance through it and then move on. I think a better way to look at it is, and which isn't really taught in school, is that what value does PDMP provide, right? Because if we don't see PDMP or the information from PDMP as having any kind of value, then we definitely are not using it as wisely as we should. But then if we break it down into like the granular level, like what Shelley was doing earlier, is you take a look at whether or not the patient have any kind of like controlled substance fill history, right? Because the first thing that the PDMP will allow us to do is you have a snapshot of what the patient is filling in the past 2 years. I think 2 years is like the cutoff. And then the other thing that it really allows you to see is what are the changes in terms of the dosing over time. Because when you go into the room and talk to a patient, let it be inpatient or outpatient, you want to build rapport as fast as you can. And one of the things that you can really build rapport with the patient is do your homework. And so if you see any kind of changes in terms of dosing or any kind of new medication on PDMP, that's a good conversation starter instead of going in there almost like blindsided and not knowing what's going on. And so with PDMP, that gives you a leg up and serve as a conversation starter. And the other thing, like Shelley was saying, is that it allows you to perform not just from the dosing standpoint, right? Because in terms of the opioid safety and how we can really help with the opioid crisis is that if we see any kind of pattern of, for example, doctor shopping or patient go to different pharmacies, and of course now with pharmacy closing down, and that's another kind of like a noise, right? So we have to be very careful interpreting what does it mean to be doctor shopping? What does it mean to be like changing pharmacy? And I think those are all the good information that PDMP is feeding us. So it really, the core question is, are we realizing those are actually the gold? Like PDMP, the government or you guys, spent a lot of money and resources into this program. So I think really like how are we utilizing this program and are we really using it to the maximum capacity? So that's how I see PDMP and the value of that.
Seeing, what's your experience been in terms of, are physicians using the PDMP in the same way that you're using it as a pharmacist? We know that all 50 states now have access to some flavor of a prescription drug monitoring program. So theoretically, everybody should have access to use these tools in the same way and get the same use cases out of them. Are you seeing that providers and physicians in different health settings are using it to this capacity, or is it being used as a checks and balances system when prescribing narcotics only?
I think that's such a good question because I think it really ties to, different almost like kind of like the shortcomings in terms of our current practice, right? And I would say I see like a mix 50-50, and Shelley, definitely share your point of view after, what I'm sharing, because we do want to hear, in two different settings, what are we really seeing? But for me, if say, for example, for like physicians who have been practicing for some time, they have more experience in terms of interpreting or even having that as a habit, right? Because reviewing PDMP as a habit versus even not reviewing it as part of the habit, that makes a huge difference. I would say that with physicians like who are new grads or residents, and those are like the group that has like a bit of a learning curve, because some of the things that we almost like we're not acknowledging as well as we should is that, and I can speak for myself, is that back in pharmacy school or even when I was doing rotations, so basically kind of the on-site apprenticeship. And so even in those times when it comes to reviewing PDMP, like the knowledge or the teaching that I receive isn't necessarily the most robust. And I'm not saying that it's anything bad, but if you ask around, right, if we ask around different physicians from different area, let it be pharmacists or PA or, physicians, then it seems to be like there is a lack of education when it comes to pain management and specifically pain medication management, right? Because we hear pain medication or pain management a lot, right? We know the general concept: use the least effective, minimum effective dose, and be mindful of the interaction. Know that it's a very risky medication, and pretty much that's that. But the in-depth education of PDMP sometimes is lacking. And even for my training, when I'm training like residents or new practitioners, I tend to see that that is something that's lacking. The in-depth interpretation, the knowledge of how to utilize it, like you said, is lacking. So that's what I see. And I was wondering if Shelley has a different viewpoint or it's something similar.
Absolutely something similar to Sing Ping. The issues that we face are similar, but specific to our work settings. I agree that new providers, into new graduates, have no idea, and so catching them to explain, hey, this should not be just a knee-jerk thing because we have to if we're giving them a prescription. It should be part of your workup, like an assessment of any patient, not just a pain, because it does controlled substances, benzodiazepines, stimulants, some seizure medications are controlled medications. So for my state, we only have the prescription controlled substances that get reported. If I had everybody's drug report, like maybe some state does, I think that would probably be information overload for me, but just coming from, how I operate. But standardization across providers, even within a health setting that has been doing this for, as long as since I've graduated residency, so over 10 years, it's all over the place. And so that's a struggle. And it's just, you can't avoid helping. You have to educate so that they can stay up with the times and know that it's a tool in their toolbox.
So it sounds like education is one piece, or lack thereof in some cases. But I think there's also other challenges that you may not experience being part of a large health system like you are. Things I hear from other physicians and providers that I talk to, maybe in smaller medical groups or independent practices, is I would say a lack of interoperability. So a lot of PDMPs, there's varying levels of connectivity. Some states don't allow for any interstate data queries. Other states, have numbers as high as 48 and everything in between. So I think that's one thing, is especially for states that are bordered and have patients that are crossing state lines, having interstate data available is one challenge that providers experience that you may not. Another is really just integration within the EHR system. So I think Sing Ping and Shelley, you both have in one-click integration available where you're in a patient's chart in your pharmacy system, and you can one-click access their PDMP record. So some providers in smaller health systems don't have that one-click access, and what that looks like is administrative burden. These providers are already operating at maximum, and so when you have to go into the state PDMP through another website, remember your login credentials, or hopefully remember them, and then do a patient search, making sure that you are on the right patient, viewing the right record. Those are all things that take time, and oftentimes in these smaller systems, or the providers that don't have that direct access, they're delegating that responsibility out, from what I've seen, to another member of the clinical team. And I think that can oftentimes remove the physician or the provider from having that kind of direct ability to look and have a conversation with the patient based on something they may see in the record.
Totally agree. When we first got it, it was a manual query. I do border state lines, so I needed the neighboring states' data, and we had access to both. And then we had, I'm in a federal system, so that reporting wasn't immediately available to states because of privacy concerns for military and veterans. But now it has. But back then, I was, doing these manual queries, so I can absolutely relate to the typing your password in 99 times in a day and then documenting that you're doing it, because you're told, if you query it, you got to document, and it just moves away. And even having a surrogate, moves away, like you said, from the clinical decision being with the person that's ultimately responsible. So yeah, if you have a surrogate that may seem to help your time, but you still are ultimately responsible for what is that surrogate has put in that note. And, if you haven't laid your eyes on it, then you better be confident that in the person that is your surrogate. So that just still goes back to, if you're in that setting, it's not trying to reframe it as not a burden. It's a tool that, is needed to provide necessary care for people who do technically have to query it to order a prescription, because of state laws usually say if it's a controlled substance at a new prescription or a dose change of the higher of C2s, you would need a new PDMP. And so it's a tool. And again, education and empathy, because I've been there, and it's not fun resetting your password 4 times in a week, because I've done it. And if our system's down, we have to log in manually. And Lord knows I haven't remembered my password from 6 months ago when it was last down. And so I have to reset it. And it's gotten easier because it'll text you, but at least in our state. So
when things like that happen, the line starts getting longer at the pharmacy. Patients start to stack up in the waiting room, and can be stressful. So I think having that integration certainly would certainly help providers be enabled to take a longer glance at their medication, both historical and current meds, and at least help start a conversation with the patient about anything alarming they may see. In your organization, you're able to query multiple states to get data back. I know that we talked about that. Have y'all experienced any challenges with patient matching or patient identification, making sure that you're in the right patient's record? And have you experienced any challenges like that?
I actually, now that you bring that up, I have a case actually, this week that on the PDMP, it says that the patient has been filling benzodiazepine for a few months. And so when I asked the patient about doing like the medication reconciliation and see whether or not I should resume that medication, and the patient said no, like the patient is not taking any benzodiazepine for a long time, and it was like a long history. So when I go back and take a second look at the PDMP, it's funny because when the patient have very similar last name, I guess it's almost like a syntax error. Then they would pull very similar patient who have like the same birthday, very similar last name, but their address is completely different, right? And so the wrong entry, that patient is living in some other state, and so that can happen. And so again, it takes, really a lot of attention to kind of piece together what you're seeing. And I would say, before you try to confront the patient, so to speak, right, you want to make sure that you lead with empathy and really don't assume and jump to conclusion, because things like this happen and it's really not the patient's fault, and it's the technological problem here.
same. We've grown and it's gotten better, but there's specific privacy stuff that it's not like a identifiable. It's not your social security number that they're linking. So common last names and birthdays, it will. And on our side, for where I'm at, you see that, hey, there's multiple patients that may not all be the exact, and it's not, it's at the top of the query. So that can alert you, but you got to read it. You can't then just click it and then click out. And then withholding a medication or starting a medication that they're not on has been an issue in my experience. And I only spent a lot of time on one where I worked really hard to have that patient's profile separated from someone that had the same first name, same last name, same birthday, and was in a completely different part of the country. And it was tough. And I had to hand off to some people that work in our system with PDMP, and not everybody has that opportunity. So, again, back to you got to be careful. You got to, you still got to look at it. And it's technology, and technology is not perfect. I will die on that hill that technology is not perfect.
I think that's an area that as a whole can be improved upon. And what I've seen is it really depends on where you are, both the state that you're working in and the organization that you're working for or are employed by. So, for example, some states their PDMP is connected to a health information exchange. And so what I've seen in those scenarios there's a master patient index on the back end. They're being fed data from multiple sources. So they have more to use to aggregate and make sure that you have the correct patient, whereas some states are not. And you're really just basing it off of identifiers that you're trying to match up, your name, first name, last name, date of birth, which can be shared. I've seen situations where a nickname or a shortened name were used, and that skewed the results. We'll get to the future of what we want PDMPs to look like and act like here in a minute, but I think it's important that we also look at integration with national health data exchanges and common frameworks using eHealth Exchange, Care Quality, Care Anywhere as tools to help enrich the data and make sure that we've got good patient matching on the back end to take or alleviate some of the work that clinicians are having to do to get meaningful use out of the platform. So, Singping and Shelley, what are some of the other challenges that you experience when using and evaluating the prescription drug monitoring program? What are some things that may be sticking points for other physicians, members of the clinical team, or pharmacists from getting meaningful use out of this, or being able to properly do their due diligence in a timely manner?
I'm going to start first, and I know it's going to sound silly if I call it out, but time is money. Right now, with our current system, it still takes right around 30 seconds from the time you click what we call the PDMP button to the actual time of having it loaded. It's right around that time. So I would say that if, I don't mind the 30 seconds, but I want the, time to load the data to be as short as possible. So then we don't even hear the excuse of take maybe the PDMP button is taking too long for it to load and it discourages physicians from using it. So if in the most idealistic scenario is if we can shorten the time from 1 to 2 seconds, you click it, it pops up, I can see the thing, that would be perfect. But I know, it's going to be a work in progress. It's never going to be that perfect. So I know it's silly to say that, but.
Well, I don't think it's silly at all. And I think if you were to poll all the providers, 99% of them would tell you that 30 seconds is a lifetime when you're sitting there in front of a patient or waiting to get on to the next one. So certainly don't think that's an odd call out and something that could be improved upon. Shelley, what are your thoughts?
Well, Singping's living on Mars, and I don't know that could happen, but it would be lovely to be more efficient in the process. As someone who does have that issue when I'm going to order the prescription because it's a requirement. So I have to do that note at that time to then go on to process to order a controlled substance. So I can't skip it. And, it's going to take the time it's going to take. And it does feel like a lifetime when someone's looking at you, basically the patient right in front of me. The other thing, if we are still living on Mars and had it in a perfect world, would be maybe if it was felt more like real-time data. Right now, at least locally, I still tell people that it may be days before a prescription that was filled would show up on our state's database. It probably has gotten quicker. I used to say 7 days, and I do believe it did used to take that long for it to get all onto the chart. I mean, to the query. But the lack of real-time data has kind of bit me in the butt before, where I'm prescribing a patient who previously had a different prescriber. I've taken over. They're not supposed to go to any other providers. They know that. And at that time, when I'm ordering the medication, it looks like everything is just me lately, and we're going to go on this process. And then not 2 days. Well, when I see them next time, I do a query, and it shows that actually the same drug was filled the day prior. So I didn't have that data, and I was basically a duplication, and a risk of issue when we're dealing with high risk medications. Certainly an aberrancy on the patient. They are, they are with it enough to know that they did something wrong. But if we had a tool that we felt more confident that we had that actual day of data, would be great. And if it was within the last hour, I would think that we were living on Mars, but it would be great.
Yeah, that's a great point. And clinicians, physicians, pharmacists aren't mind readers, and so they can only make decisions based on the best data that they have in front of them at the time. So agree with you that real-time data in the clinical setting is a key factor and something that we need to strive to improve. I think some states are probably better equipped to do that, but as we look into the future, I have a magic wand. I can fix everything. I think,
Let's hear it.
I think, really what I see in the future of PDMPs are national interoperability, like we called out, seamless sharing of data across all 50 states, integration with those national health exchanges to help aggregate better data and patient matching, real-time data, like you mentioned, making sure that what I'm seeing is the most up-to-date by the minute data on that patient, seamless EHR integration. So not just for the big shops, but for every provider being able to have that one-click access, patient-centric search where your patient is already coming up based on the chart that you're in, incorporating that data into the existing workflows of the physician. So during your medication reconciliation, having that data available so you can do those checks, and any prescribing that you might do in that visit will be able to take advantage of any drug interaction checks that may be available. Getting into that more like predictive analytics, clinical decision support, what tools can we provide within the integration to allow the physician to check or catch things before they go out the door that may be an issue, and provide therapeutic alternatives to that drug. And then, really something I'd like to see in the future is patient empowerment. Why are clinicians and pharmacists the only ones who are allowed to see the PDMP data? I think making that available to patients, whether it be through the portal or through a report that you provide in their record, I think that builds trust and transparency and alleviates a lot of questions that patients may have about why they may or may not receive certain medications, or why these conversations are being had with them by their clinicians and pharmacists.
Having patients, to be able to access to their own, PDMP is important because, Shelley and I were just literally talking about how there are mix up of patient record, right? And the unfortunate fact is, what we see is all there is. And so when we see that there is something there that's not matching, then sometimes a lot of us, we would start to question, and instead of jumping into the mindset of questioning or have any kind of doubts, I think it will, like you said, it will be very transparent from the patient perspective, and just be it, because thing is, it's almost like it's part of their health record, right? So if they have access to just the chart or the labs, I know this might be something that they should also have access to. So then for any dispute, like any kind of like record mix up, like we were talking about, then the patient will probably be the best person to call that out and resolve any kind of like conflict before that even happens, and they can advocate for themselves.
So good. And it goes back to, how Ping and I operate is in a patient-centered model of, letting the patient collaborate. It's not a dictatorship, working with them in this tough field of pain management. Now, we are in just one of the specialties that is involved in controlled substances, but I think using the term empowering patients is excellent, and they know themselves the best. They can prove that they didn't live somewhere if there's an address discrepancy, and it would be, I think that's an efficient way to solve some of the issues that may not be able to be fixed by everything that you are trying to obtain. So I appreciate your efforts, and it's amazing what it could be in the next 10 years. It's evolved so much since I started. So I'm excited to see it, how it's utilized going forward.
Well, Shelley and Ping, thank you for all the insights you've provided. Both have a wealth of information and kind of a unique perspective on PDMPs. My favorite part of the show, I'd like to jump into getting to know you both a little bit better on a personal level. You don't have to overshare, but I'd just like to pose the question of, what got you into pharmacy? Is it something that you wanted to be ever since you were young children, or is this something that became a passion along the way?
I'll start. My desire to become a pharmacist did not start at the wee ages of when I was first asked, what do you want to be? my answer to that question was I wanted to grow up and be Bob Vila. And so obviously that dates me back to, to the generation, if anybody knew who Bob Vila was. And that is the answer that my parents sent me to school to hang up on the school chalkboard. But I don't come from a background of medical providers in my family. I had a lovely advisor in college, and he said, you're on the track to, you could do this. And, I was like, I have the credits to apply to pharmacy school. Okay. And I am just blessed to be in a position where I'm making a difference and doing the highest of clinical things that a clinical pharmacist can do. Specifically, pain management was related to a very good rotation that I had on my clinicals. The second rotation of my clinical year, so final year of pharmacy school, and the impact that it had on me. And it was a pain management and palliative care, so hospice-like rotation. And I ended up becoming the preceptor for that same experience for others. And so I really was dedicated to teaching. And then I'm involved in our residency that I did. And Sing Ping was one of our residents that we trained, and he's flourishing. So it's not an exciting story, but it's different than becoming Bob Vila. So that's all I got.
What's your origin story, Sing Ping?
Oof. So a little bit of confession, I don't have a glamorous, I grew up wanting to be a pharmacist story either. Not that my dad is, a doctor, my mom, is a PhD. No, I don't have that. Um, so when I finished at the time, I was really kind of thinking about what to do, like what kind of career can I pursue? At the time, I had like a biochemistry degree, and really I wasn't quite ready for any kind of career at the point. I was immature at the time. And so at that time, I know that, okay, maybe, right? I wanted to do medical field. And I knew at the time I was too nervous to apply for medical school. And I know I didn't at the time, okay? At the time, I didn't want to have, touching patients. And I think that's, for the most part, that's the reason why people don't want to do nursing, because you have to do a lot of like touching and managing patients on the very, very frontline perspective. So at the time, I didn't have dentistry in my back pocket. I didn't have ophthalmology, whatever. At the time, I only knew pharmacy, medicine, and nursing. So I was like, guess what? I'm just going to do pharmacy at the time. So I didn't really know what pharmacy really was until the second semester. I hate to say it because I didn't even work at a pharmacy even before enrolling in pharmacy school, and I discovered what pharmacy was at the time. So if anyone is hearing this podcast thinking you want to do pharmacy, just take a rotation, work at a retail store before ask someone who is a pharmacist, or DM us, or whatever. Just ask us or get a good idea what pharmacy really is. And then, so I become a pharmacist, I graduated. And at the time, I didn't know. After I finished the first year of residency, I was, again, kind of thinking about what I want to do next. And so one of my mentor, um, her name's Laura, and she was like, "Hey, Ping, why don't you check out pain management?" Because she was my preceptor in a geriatric rotation, and she said, "You have that kind of people skill to do that." So I was like, okay. So at the time, I didn't really know what pain management really was. But I think after I started the residency with Shelley and my good mentor Scott, and then that really changed my trajectory, because at the time I thought, okay, pain management back in the first year residency, I knew how to manage opioid, but I didn't realize, oh, there's a next level of thing called pain management, and all that you do is not some superficial level of opioid management. It's a deep dive, and there is almost like a emotional intelligence requirement for that, because you have to navigate all that emotion and suffering with the patients. And really, after I discover that, pain management requires a lot of problem solving, a lot of people skill, that really got me hooked. And so now I've been a pain pharmacist for 3 years now. So that's kind of how I started in becoming a pain pharmacist. Not a glamorous story, but
I think it's
then,
great.
Yeah.
it clicked, and then I'm loving what I do now.
Just like Bob Ross, it's okay to have happy accidents, right? And find things along the way.
No, you
But
sound like that stuff.
Definitely.
no, I'm just curious also, when you specialize in pain pharmacy, pain management, those, do they give you any training on how to communicate with patients, or is that just something you have to hone your skills at as you go along?
I think it's been both. I couldn't have had better mentors in my career that started when Sing Ping was a baby. So in my residency years, which residency for pharmacists is not required, if you want to work in a clinical setting, managing patients, it is the route to do that is typically through a residency, but by no means do you have to do it. People get hired from pharmacy school into clinical positions, but we were residents alongside medical residents, and I had my residency director at the time was also named Scott. It's a different Scott than was Sing Ping's, but the confidence he had and the effect he had on an interdisciplinary team was just like, it was amazing. And it was like, I could never fathom having that much confidence in helping a patient until that rotation. And I was like, I'm sold. I need to do this. And I want to care for these people. Pain management is not, nobody's knocking at our door to take our jobs. And I'm not saying that with like, oh, I'm bragging. No, it's a tough job and it does have burnout, but it's been great. And I had good mentors, but you do have to learn how to speak to them. And I had the medical doctors that were in our training and in residency that could talk very, very sternly about, life after traditional opioids. I still say that to patients. And I heard the doctor say that to them. And this is I finished residency as if it was like destiny for me to be involved in opiate stewardship when the opioid safety initiatives and all this regulation came down because of the peak of opiate prescribing and the issue going on. Now we're still 15 years later in an evolving opiate epidemic, but it's not the same as when I finished my residency. But it was like, I'm going to be doing this for the rest of my career, and I was just primed for it. But him being able to have the stern conversations really helped me in talking to patients on a like eye-to-eye level, being clear with them, and then having the palliative care side that's involved in all pain management residencies with pharmacy. It's pain management and palliative care, the compassion that's involved in that. And it's just it's a perfect, I think, training opportunity based on where you are to be a very good, well-rounded provider. And that's what I am. I have provider status in how I do it. And I never would have thought I would have gone and gotten my DEA. Like I would have said, that's not happening. You can have all my savings. I'll bet it against you, kind of thing. And here I am managing patients, pretty much independently based on my scope of practice. So that was a long answer to your question.
Great answer though. Shelley, Sing Ping, I know that you guys recently rejoined forces to create PainRX Consulting. Can you tell our listeners a little bit about that? What is it exactly that you do as consultants?
As we have mentioned in various parts during the podcast, is that one of the gap in the current system when it comes to pain management, and specifically pain medication management, is the lack of education. So back in school, we didn't really have a lot of training, and during residency, unless you do something very specialized, and even then, the medication management part is still not a lot of strong suit for a lot of physicians. And that doesn't just happen in America. I think it's happening in a lot of other places in the world as well. And so what we are focusing, number one, is education. We do a lot of education on our LinkedIn, and, we try to do pocket guides for clinicians. And what we're also trying to help is implementing systems and protocols, templates, and really refining the current process and also program, because a lot of current systems in a lot of hospital systems right now, they're not really investing in pain management pharmacists, right? Because how many times have we encounter like talk to new physicians and then they would look shocked when they hear that, oh, you're a pain management pharmacist, like what do you even do, right? So we hear that, and so that's where we really fill in the gap. So we are really there to take the practice to the next level through that collaboration, and that's what PainRX is really offering.
Yeah. So are you helping physicians and health systems with identifying trends that you may see in the PDMP? Is it coming up with taper strategies or alternative treatment methods?
It's all of that. What we dreamed, and rip the band-aid off, because if not now, when? It's never going to feel like a good time to try to take this excursion that we're doing. It's an additional thing to our usual jobs. It's not paying all of our bills by any means yet, but we hope to empower providers to care for patients as a whole patient. In the age of the opioid epidemic, a lot of providers, primary care, specialty even, are saying, I'm not comfortable, or this, you can go here and get help, and instead, this is something that any provider can do, and can manage patients and see them as humans. And that was really my hope, that we could help empower the provider side, because it's been fear of regulation, fear of all these rules, fear of or distaste for having to do documentation. Help that and be there as resources who are doing it. I'm not claiming. I'm very clear when a patient calls me Dr. Fortner, I'm like, don't go around saying that you're pain doctor, Dr. Fortner. You can say, I have a pain pharmacist who has a doctorate, but I'm not trying to replace a medical provider. I can't do that by law. So we want to work together like we are currently in our in what we're doing on a day-to-day basis, and expand that to help pain care across all settings. So mainly on the provider system side, however we can help with their stewardship. Some of the stuff it's absolutely required by Joint Commission or accreditation standards to do things. And, rather than making that, like Singping has mentioned, a checkbox, or okay, I click this and then I'm done, I get, move on, how you can really use that to your advantage and help the patients, because we would hope that there are others out there that really want to help patients, or people shouldn't be in healthcare. So that's what we're trying to do.
I think it's great work, and also appreciate all the snippets of information that you put in short form videos on LinkedIn for guys like me to stumble across and learn a thing or two. For any of our listeners that, whether it's a clinician, a doctor, an administrator in a health system, that may want to get in touch with you in order to learn some information or possibly get some help in their opioid stewardship programs, what's the best way for them to contact you?
We have multiple channels, so definitely check out our website. Our website is PainRXConsulting.com. And then we are very active on LinkedIn. So I'm pretty sure there's only one Singping Chow on LinkedIn that does pain.
That's
And there's
guaranteed.
also only one Shelley Fortner who's so passionate about writing pain medications. And I'm pretty sure the reason you and I connect in the first place is because I'm pretty confident on that, is that I'm probably one of the few people who was writing about PDMP and really educating, doing the content of why it's so valuable. So Shelley and I are one of the few pharmacists out there who's trying to put and really spread our seeds, our knowledge, across the globe. That's our goal. So then, we can really better the care. So our website, PainRXConsulting.com, our LinkedIn, and you can also email us at PainRXConsulting@gmail.com. So those are the best ways to contact us.
Well, Shelley and Sing Ping, thank you so much for joining me on this maiden voyage of being a podcast host. It was a real pleasure. I hope we can get you back on and dive a little deeper into prescription drug monitoring programs in the future. But again, thank you for being here. This concludes an episode of the Next Orbit podcast. Until next time.
The Next Orbit podcast requires more than a conversation. It takes action, research, and collective wisdom. If today's episode resonated with you, we'd love to hear your insights. Join the conversation and help us shape the future together. We'll be back with more stories, strategies, and real-world solutions that are making a difference. In the meantime, be sure to subscribe, write a review, and share it with someone you think would benefit. Thanks for listening, and we'll see you on the next episode.